So thank you, Luisa. Thank you to Marta and Zach for getting me excited to be a part of the program, in addition to part of the organization. And today, I'm going to talk to you about work we do at the neuropsychiatry unit, about how brain lesions can help us understand disorders of emotion. I have some disclosures, and I'd like to put them up. So maybe this is a characteristic of physicians. We always do this, and we typically have them. I'm going to talk very briefly about some work that's sponsored by Janssen, but the majority of the work I'm going to talk to you about is of investigator-initiated studies here at the Champalimaud Foundation. And also because I'm typically very bad at timing my talks, I start with acknowledgements. So this is the lab. Or it was the lab, maybe a year ago, it's changed. And I show this picture first so that I don't scare people with the real picture, which is this one, which is a picture that has the lab and the clinic and the several people in the clinic and in the research unit with whom we collaborate most closely. And the special thing about the people that I work with, in addition to their personalities, and very healthy personalities, is that we are clinicians and researchers, and some researchers that have clinical training that are working and collaborating very closely to try to solve problems that are relevant for clinical practice. And I also have some other names here of affiliated staff and people that were in the lab in the past. So the plan for today is that I'm going to talk to you briefly about disorders of emotion. Then I'm going to bring up a clinical case of a patient with mania that I saw when I was a resident in psychiatry, try to talk about the research that was inspired by that patient, and discuss where this is taking us in terms of the research that we're planning to do. And we've heard a lot about emotions in this meeting up until now. We've had great talks yesterday, today. We're expecting another fantastic talk later on today. And if I was going to talk about definitions of emotions and describe them to you, I would clearly not have time for the rest of the talk. So I'm glad that there were others that discussed this in detail. But we also have talks about elements that start to touch on what are the disorders that can affect this function. So fear and freezing have been very much used to look at disorders that in psychiatry we classify as stress and anxiety disorders. And then there are other quite complex disorders called mood disorders that we're very much interested here that may have polarity between low mood, depression, and high mood and mania that are very much reminiscent of some of the appetitive and aversive modulation of certain brain circuits that are in part involved in what we call mood disorders in the clinic. And why are mood disorders, depression in particular, and anxiety, why are they important? Why should we worry about them? So one of the reasons that we should worry about them is that even if we don't have a psychiatric disorder, depression and anxiety are part of our day-to-day life. So they're part on how we adapt to challenges. And if you were around in the poster sessions for the last couple of days, you might have heard Berta Souza, who's an oncologist here at the Champalimaud, and Raquel Lemos, who's a professor of psychology and a postdoc, talk about the work that they do, looking at how a diagnosis of breast cancer is relevant in terms of the emotional processing of several different elements and of cognition. You might also have heard Sylvia, who's a clinical psychologist in the clinic, talk about the work that she's done trying to understand how COVID impacted adaptation to a diagnosis of cancer, of breast cancer, in the same cohort. Or even José, who's a psychiatrist in the neuropsychiatry unit, who's interested in understanding how inflammation can participate and contribute to this whole process. And when adaptation isn't successful, or in other circumstances that might not be at all related to the environment, you transition into mental disease or into mental health disorders. And we're very much interested in treatment-resistant depression. And that's the condition where, when you do have a depressive episode that is diagnosed, and you do the typical first-line treatments to get it resolved, it doesn't work. And so we have people that are interested in the first-line treatments. This is a work that is ongoing, looking at how psychotherapy can be useful in the treatment of patients with cancer that are also depressed. And in the realm of treatment-resistant depression, we've been also looking into the more classical medication-based trials, trying to understand how different substances can be more or less effective in getting people out of depression. We're concerned, and you might have seen Carolina, another clinical psychologist in the unit, talking about the concerns and the limitations in how these are applied in the clinic. And one very specific theme that we're very interested in, both in the clinic and in research perspectives, is how brain stimulation, don't worry, this is not a clinician or a student in the lab, this is just a picture from the internet. So on how brain stimulation, and specifically how focal brain stimulation can be used to treat individuals that have not responded to medication. And neuroscience has had a role in how we look at and understand depression. And I'm bringing this paper back. This is a very, very old work from 1994, and I'm bringing it all the way back because we tend to forget that not that long ago, the big question was, is depression, does it have anything to do with the brain at all, right? And very important seminal work looking at the physiology of the brains of people with depression and the brains of people that did not have depression, identified certain areas that are modified in their function between these two populations. And other seminal work by, work by Helen Mayberg, already classical work, showing how the brain changes when people improve from depression when they're treated, and a very interesting thing, how it's similar between people that respond to an antidepressant and people that respond, that get better when they receive a placebo. And finally, in more recent work, the idea that looking at connectivity profiles in the brains of people with depression can help us understand who will respond better or worse to different kinds of treatments. But all of this is to a large degree correlational, right? And in many instances, it's hard to extract meaningful information from correlation. But it has been done, and sometimes successfully. So this is also a review paper looking at the rationale under which a specific protocol for deep brain stimulation was developed to treat depression by the group of Helen Mayberg. And Helen, who did, as I showed previously, lots of work with functional activity in the brain of people with depression, looked at evidence that when you induce sad memory, when you induce low mood through tryptophan depletion, you have an increase in the activity of this area of the subgenual cingulate cortex, or the fact that this area was also modified in patients that have a genetic polymorphism that could increase their risk for depression, and also the fact that in people that die while they were depressed, there is a change in the anatomy of this area. And the other thing that Helen observed was that in people that improve from depression across several different treatments, you have a reduction in the activity of this area. And this led Helen to propose and test subgenual cingulate cortex deep brain stimulation for treatment of depression with reasonable levels of success. And going back to non-invasive brain stimulation that has been developed using pretty rudimentary, superficial localization techniques since the late 90s, the fact that we were stimulating a place at the surface of the dorsolateral prefrontal cortex that was inducing similar effects in terms of antidepressant, so reduction of depression symptoms, to what was observed with subgenual cingulate cortex deep brain stimulation, led to the idea that maybe there was a relationship between the effect of stimulating the surface of the brain and the connectivity that that specific area had with the subgenual cingulate cortex. And there was some evidence to suggest that that was true, that negative connectivity was predictive of the improvement of depression when you stimulated the superficial area of the cortex. And that indeed led to the development of novel protocols where the localization of treatment is now no longer done by surface elements of anatomy, but rather is done by the individual connectivity between the dorsolateral prefrontal cortex and the subgenual cingulate cortex. And this, among other changes, has led to the development of these very exciting protocols of brain stimulation for depression that seem to be very much more effective than anything else that we have available. So, I've talked a lot about depression. Depression is something that we're very interested in. But the patient that I'm going to discuss is actually a patient that developed mania. And mania is the opposite pole of bipolar disorder. And not all patients with depression will have mania. But any patient with mania will typically also have depressive episodes and have what we call bipolar disease or disorder. And this is a case report of a 76-year-old man who had a first episode mania. He had had in the past treatment-resistant depression, and this is the description of the symptom, right? Of the syndrome, sorry. He had elevated mood, he had increased sexual activity, he was spending lots of money, and he had these ideas of grandiose capacity. And as you can imagine, this made everyone except him worried. He was taken to the hospital. He was put under inpatient care in the psychiatric unit. And of course, being a 76-year-old person that has a first episode mania, which is quite atypical, one of the things that needed to be done was look at his brain. And his brain looked pretty normal. And he improved with prototypical treatments for bipolar disorder. But then he started to deteriorate. And when he deteriorated, that was when he was under my care. We repeated his brain imaging, and he had a huge brain tumor in the right frontotemporal lobes that we believe was probably already present in the original brain scan, but that was not visible with the level of resolution that we had at the time. And this got us interested in understanding how such a process could occur, right? How does a brain lesion lead to this relatively complex syndrome? And one of the things that was particularly interesting for us was the fact that there was lots of evidence that lesions in the right side of the brain, and this was textbook kind of domain, lesions in the right side of the brain cause mania, lesions on the left side of the brain cause depression. But there was no good rationale about where these lesions were distributed, and it was not clear to us why this would happen, why you would have this laterality effect. So we went on, and Bernardo Barona Correia, psychiatrist at the Champalimaud neuropsychiatry unit, led this work looking at all published cases of lesional mania in the literature. And we found just over 200 described cases, and we looked at the distribution of these lesions in these patients as they were described in the papers. And we confirmed that, in fact, there was a huge mismatch between the left and the right side that was clearly biased towards right-sided lesions. And this was not due to an effect in a specific... So I'm sorry, the pointer isn't working. This was not due to an effect on any particular brain area. This was distributed across many different brain areas. And indeed, we went ahead. Some of these images, we had access to them, we traced them, we overlapped them on a common brain atlas. We looked at how this was distributed across different areas of the brain. And the first thing we did was, for the lesions that we had a comparison between left and right, we compared left versus right in the two hemispheres of these patients and saw which areas would be more represented on the right than the left. And you see that there's clearly a distribution that's not entirely distributed. There seems to be some increased overlap in these temporal areas. But this is the number of patients of maximal overlap, right? Maximal overlap in 56 patients is in 9 patients. So there's some overlap there, but this is not particularly exciting. And the other thing we did, because brain lesions, particularly stroke, are not randomly distributed in brain tissue, they have a specific distribution according to the vasculature, was that we then concentrated only on lesions that were resulting from stroke, and we compared them with control lesions that were also due to stroke, but had not resulted specifically in mania. And we saw if there was any commonality with our left-right-hand side comparison. And indeed, there were several areas that were represented both in our left-to-right comparison and in our comparison between stroke lesions leading to mania and control stroke lesions. And these were right temporal regions, the right fusiform gyrus, and the right thalamus. So we're getting somewhere, but still quite distributed, and still not that many patients overlapping. So our next question was, what may be the associated brain networks? Is it that these different lesions that are representing a smaller number of patients are just representing lesions that are then connected to a specific brain circuit? And is this brain circuit informative in any way? And the way we targeted this was that we then looked at each lesion location, and we went to a large database of functional resting state magnetic resonance. Okay. So resting state functional magnetic resonance, to try to understand the connectivity profile of these lesion locations to the rest of the brain in healthy individuals. So trying to have an understanding of what the connectivity was before this lesion occurred. Okay. So we look at the mean bolt signal change in a time series for that lesion location. We then do correlations with each voxel in the remainder of the brain of a non-diseased individual. And we have a connectivity map that will be of voxels that are firing, or the activity of which is correlated with the activity of our region of interest, and others that are anti-correlated, so that seem to have negative connectivity. And we have access to these large normative connectomes, so lots of resting state fMRI data from lots of individuals. We repeat this across each healthy individual in the connectome. We do it across 1,000, in this original work, across 1,000 individuals, and that gives us a mean connectivity map for that particular lesion location. And this was something that was developed by Mike Fox in Harvard and Gonçalo Cotovio, who's represented here, who is a psychiatry resident and was a very talented PhD student. He now has completed his PhD. So he went over to Harvard, learned from Mike, and brought this back to do a comparison between the mean normative functional connectivity of these lesions that led to mania and the mean functional connectivity of control lesions. This was the mean connectivity map that resulted from this comparison, and we did this in 2 different cohorts. We did it in the cohort that we had extracted from the literature, and we did it in our own clinical cohort where we had 3D lesions available. And what was very interesting for us was that there was a reasonable amount of overlap between these 2 analyses that were done in 2 very different cohorts of patients, and they were concentrating on the right frontal pole, the right orbitofrontal cortex, and the right inferior temporal gyrus. And because there's lots of ways in which this analysis can go wrong, we then did lots of different analyses, trying to control for clinical factors, trying to use different control series of patients, combining all of these different criteria together, and essentially the same areas came up. And then we also did another thing in another paper. We went on and we used different connectomes, different normative connectomes. So could this be specific to the connectome we were using? And we used all of these different connectomes, and the result was quite consistent. And this got people excited, and we got a request from Stanford to send them our connectivity map because they wanted to use it for a trial of TMS. Last time I heard, they're having a really hard time It's very hard to do brain stimulation trials, and it's particularly hard to do it in patients with mania, and so that's complicated for them. But that did inspire us to think about how we could use this approach to develop new therapeutic protocols in other conditions. And we also have been looking at how these connectivity networks can tell us something about the side effects of treatment, because this is always a problem, right? Treatments are not only good for you, sometimes they cause side effects. And brain stimulation can cause side effects. One of the side effects that it can cause, for example, is mania. Okay? So you can do TMS for depression and actually induce mania, or you can do deep brain stimulation for Parkinson's disease or for OCD, and you can induce mania. So we were interested in understanding if our lesional network map for lesional mania was informative about these brain stimulation protocols that could treat or induce mania. And indeed, the connectivity profile is very different. Areas that we stimulate and cause mania have a very different connectivity profile to lesional mania than areas that we stimulate to treat mania. And you can also have these very dramatic effects in inducing acute depression or even acute mania with deep brain stimulation. So deep brain stimulation seems very promising in looking at this carefully. And Gonçalo also did this and showed that DBS targets that cause mania have this very different profile of connectivity with the lesional mania network to DBS, to standard DBS targets. And we have an ongoing project, I'm not going to talk about it, where we're collecting data from hospitals across the country that are treating patients with deep brain stimulation and collecting evidence from individuals that develop mania and control individuals that don't to confirm this data. Marcelo Mendonça, here represented a very recent neurologist in our group, is of course very interested in DBS and the use of DBS for motor, for movement disorders, and he's interested in other kinds of side effects of deep brain stimulation, and he has paired up with Gonçalo and with Francisco, that are the people that have developed all of these technology in the lab, to start looking at other syndromes, and particularly in Parkinsonism as a side effect of DBS rather than a focus of treatment. So what have I told you? Today I've told you that repetitive transcranial magnetic stimulation is an approach for human non-invasive focal brain stimulation with therapeutic use in depression and with therapeutic use in obsessive-compulsive disorder. I've also told you that normative brain connectomes can be used to define network maps underlying syndromes, psychiatric syndromes, that are induced by focal brain lesions as well as by focal brain stimulation. And hopefully, in a few years, I could be back to tell you that clinical trials have demonstrated, let's see if that's true, that these maps could be used to find targets that optimize the efficacy of brain stimulation therapeutic protocols, and or that they can be used to avoid the targets that are associated with side effects. And finally, thank our funders, thank our collaborators, again, thank all of the people that did this work, and leave you with this if you're interested in joining us back again in April for the 6th European Conference on Brain Stimulation and Mental Health. Thank you very much.